Good evening, everyone, and welcome to Incus Learning App. How to revise a topic, all the essential things within 3 minutes is the most important challenge. I'm going to give you thousands of videos, which are all quick revision bites of knowledge for you to become the topper in the tomorrow's NEET PG exam. So let's make a start with juvenile nasopharyngeal fibroma is a very, very important topic. So histologically, the juvenile nasopharyngeal fibroma is benign, and also you should remember that it is the sphenopalatine foramen from which it arises. Exclusively adolescent male. That's the reason it is called juvenile. And what is the site of origin? It is the posterior part of the nasal cavity, very close to the superior margin of the sphenopalatine foramen. Sphenopalatine foramen. The juvenile nasopharyngeal angiofibroma typically arises. What is the blood supply? Maxillary artery, unnamed branches of the internal carotid artery, and anterior pharyngeal artery supply the juvenile nasopharyngeal angiofibroma. Now, what are the two cardinal clinical features of the juvenile nasopharyngeal fibroma? There is a nasal obstruction because it's a mass, and also it produces a unprovoked intermittent epistaxis is what you have to remember. The nasal obstruction typically will lead to hyposmia, anosmia, and that bleeding will lead to chronic anemia. There's a blockage of the eustachian tube orifice leading to otalgia, deafness as the clinical presentation. And headache, it is not uncommon in long-standing cases. There can be development of diplopia because of pressure on the optic chiasma and the proptosis and a frog-like face with juvenile nasopharyngeal angiofibroma. And optic nerve can be compressed, leading to a failing vision. There's a swelling of the cheek, hearing loss, and the broadening of the nasal bridge. So how do you make the diagnosis? Anterior rhinoscopy, so that you can identify purulent nasal secretions, bowing of the nasal septum of the uninvolved side. Once the mass is causing the pressure, then there is a bowing of the nasal septum onto the uninvolved side. And posterior rhinoscopy, in a cooperative patient, it shows a pink or red mass which is filling the nasopharynx. And never do probing, that's important. So this is how you can be able to see, in case of the nasopharyngeal angiofibroma, endoscopically how you look at it, and gross appearance how it is. And this is how, like a mass lesion with the expansion of the typical frontomaxillary area, frog faces is what you typically need to remember. If you do the X-ray, what is the classical feature? Hohmann-Miller sign, which is also called antral sign. It is seen in the plain X-ray, where there is an antral bowing of the posterior wall of the maxillary sinus, which is called Hohmann-Miller sign, is what you should remember. And CT scan, especially in juvenile nasopharyngeal angiofibroma, it helps you to find the extent of the tumor. And you can see a dumbbell-shaped tumor extending into the nasal cavity. And MRI especially is very, very useful to know the extension of this soft tissue tumor. And if you do carotid angiogram, you can know the level of vascularity. And it has to be done before attempting the embolization. So these are some of the important issues about the juvenile nasopharyngeal angiofibroma. Now, how do you treat this condition? Do you want to do chemotherapy, radiotherapy, or surgery? What is your preferred choice, and in what stage you do different procedures of the juvenile nasopharyngeal angiofibroma is one of the favorite questions. So let us look into it. So typically, if you do the angiogram, this is a highly vascular tumor. You are able to see the tumor blush in the juvenile nasopharyngeal angiofibroma. And we use the rigid endoscopy in order to reach out to the tumor, which is highly vascular. And surgery, endoscopic septoplasty is being done in order to get an exposure. And you grab the this highly vascular tumor, and we remove the tumor. So this is how surgery is one of the mainstay. So this is how the tumor mask has been removed. The juvenile nasopharyngeal angiofibroma, you can see how vascular is this tumor leading to the epistaxis. So surgery or radiation, they are the main two parts of the treatment. Preoperatively, you will embolize so that all the blood vessels are being shrunken. Preoperatively, even chemotherapy is advised, where you can use flutamide in order to cause the shrinkage. And endoscopically, you can resect. So endoscopically, when you are resecting, you can go transpalatally, or a maxillary swing, or a midfacial deglobing, infratemporal fossa, etc., the approaches. So which tumors are vulnerable to endoscopic resection? Fischke stage 1, 2, stage type 3, juvenile nasopharyngeal angiofibroma is resectable endoscopically. Do you use radiation? Yes, sir. External beam radiation, especially when there is an intracranial extension or recurrent tumor, you use the external beam radiation therapy in order to treat. So this is how we make 3-minute learning videos, plenty of them on the Incus learning app. Don't forget to download and share it with your friends. And you also upload the learning videos. Thank you.